I want to thank the Wyses for inviting me today. And this, I've been to ASTM for 20 years. This is the most memorial ASTM I've been to because they introduced me to Robert Parker. So this is very unique indeed. So I'm going to talk about complication with the use of laser and energy-based device among skin of colors. These are my relevant disclosures. So I'll talk about lasers as well as focused ultrasound and very quickly on RF. Now, among skin of colors, pigmentary disturbance, especially PIH, remain to be one of the most common complications, although scarring can, of course, occur. So for the use of laser for the treatment of pigmentary conditions, we do treat congenital melanocytic nevi in my locality, simply because melanoma appears to be much lower risk as compared to Caucasian race. The typical treatment we use involve a long pulse lasers followed by multiple passes of Q-switch or pico or nanosecond devices. Sometimes we get good results, but at the same time, often we have this subtle scar that can kind of cover the nevi. It's not particularly sightly, but some patients prefer that, and often we now use non-ablative fractional to improve that further. One of the hard case to treat is Becker nevi, and we use long pulse lasers, but once again, we tend to get this hypopigmentations. Laser for treatments of freckles and antiogenous, there are many devices we can now use. We know that whether it's nanosecond or picosecond lasers, it is more effective but associated with a higher risk of post-inflammatory hyperpigmentations as compared with long pulse lasers. So if you get redness like this, the patient can have PIH that can last 6 to 12 months. And these are the publications, some that I published a quarter of a century ago, so this is pretty, reflect my biological age. And we show this. IPL also can be effective. I give my patient options. They can either have a more aggressive approach, then there's a risk of PIH that lasts 6 to 12 months, among 5 to 10%. Often I use a long pulse laser. They need 3 to 4 treatment, very low risk of PIH. And often I combine with other device to improve other component of my patient's skin. And these are my parameters. You can take a photo if you want to. I use the smaller spot size with the lowest energy to achieve immediate whitening for the Q-switch lasers. The picosecond lasers are also listed. For the long pulse, so this is before and after. For long pulse lasers, depends on what kind of long pulse laser you have in your practice. These are my typical parameters that if you want to, you can take a photo. So a long pulse KTP laser, before and after. This patients that Lantiger was treated with a long pulse Alexandra lasers without cooling. We can use compressions, pulse style lasers can be equipped with this compression windows, and we have demonstrated quite some time ago, almost 20 years ago, that this can be rather effective. So typically, with a long pulse laser, you have this crust that gradually fall over. And we published comparing different long pulse lasers as well as Q-switch lasers, and what we found was that the KTP with a cooling window with a small spot size appears to be most, in terms of efficacy and safety, to be the preferred laser. It is important when you treat skin of colors to assess contrast. Lesion and non-lesional skin is important, and try to avoid large spot size device like an IPL. So this patient, the contrast was significant. So in the middle of the area, she was treated with, this area was treated with an IPL, and you can see pretty good effect. But at the same time, for a dark-skinned individual, I don't know why she was still smiling, one of my patients, the threshold clearly overshoot, and she had this hypopigmentations. For melasma and PIH, these are my typical topical agents. Do take a photo if you want to, as well as my regimen that I start off with. Now, laser toning is very popular in Asia, but you have to bear in mind their potential side effect. And the main is these kind of hypopigmented, gut-tail hypopigmentations that we do see, especially if one overtreat. And target phototherapy can be used to improve such conditions. So this is a patient treated with target phototherapy for repigmentations. Non-ablative fractional resurfacing, the main risk is PIH, and it is important to reduce your density and increase the number of treatment sessions to reduce the risk of PIH. We do use topical steroid. We never use a systemic. And once again, I agree with my previous speakers that the use of antiviral is very important. For any discolorations, patchy is bad, uniform is good. Now, this is a patient treated with a stepping mode ablative ablative fractional resurfacing, and he developed this patchy hyperpigmentations. Of course, he was rather depressed, and we use laser toning as well as topical bleaching agent to improve it. Then he regains confidence and decided to have more treatment for his acne scar, and he did. And if you look at across the pelopolarized view, he did improve after some several treatment. But when you look at the cross-polarized view, that he developed kind of this generalized hyperpigmentations that he can accept. It's just like a 10 for gentlemen. So patchiness is bad. Okay, so you see this more generalized pigmentations. Now, ablative fractional resurfacing, it is important, and we see it from time to time. When you change the device, the percentage coverage difference. And if you mess up, things can get very, very nasty. And this is a patient treated by another dermatologist. Clearly, he used the wrong parameters. And the patient developed this persistent erythema, came to see me, and I called up the dermatologist and advised him to use a pulsed out laser and so on, so on, so on. But it really did not follow my instructions. And 9 months later, this patient come back to see me, and you can see the substantial scarring. So what I did was that I used pulsed out laser as well as steroid and 5-FU to treat the thickened scar first, and then after you can see after the pulsed out laser and steroid injection, he get better, and then I used non-ablative fractional, and then afterward ablative fractional, and so you can see after 2 to 3 years, his scar improved substantially. This is another patient with after fillers injection to the nose, scarring, and once again, ablative fractional works very well. Focused ultrasound can also have a different type of side effect that range from slight bruise to more commonly erythema and lumps around the neck. That tends to resolve, but it can develop blister too. And that's usually due to poor contact, so you really need to wash to make sure there's no air bubble. And this patient has a scar that gradually improved with various devices. Finally, radiofrequency. You can have linear erythema due to Graugen injury. Be aware to examine the tips to make sure there's no breakdown. Because if you do have breakdown, these patients can have a crust that usually gradually resolve. Bipolar radiofrequency can also cause blister and scar formations. So in conclusion, skin of color is more prone to develop pigmentary issues. RF and focused ultrasound can have a potential side effect. Thank you so much for your attention.